This is Kathy Knepfer, instructor for Nursing 2333, recording the Managing Nursing Care lecture for Chapter 12, Managing Costs and Budgets. The gross domestic product, or GDP, is the broadest measure of the health of the U.S. economy. The real gross domestic product is the output of goods and services that are produced by labor and property located in the United States. There has been an increased utilization of healthcare services. Some of the things that are happening are that unnecessary care is being provided, and this is care that does not contribute to the well-being of a patient. Consumer attitudes influence the utilization. When we need care, we have the perception that expensive, high-tech services are the best. Many still feel that the physician knows best. What about the nurse practitioner as a less costly healthcare provider? And then healthcare financing. Consumers do not feel the direct effect of healthcare costs, nor do they have a reason to have a concern. Providers price and use services based on the method of reimbursement. Pharmaceutical usage is another factor. Pharmaceutical companies appeal to consumers as well as prescribers. And then there are the changing population demographics. Consider the aging population. Disease patterns influence utilization, such as the incidence of infectious diseases, of the growing societal problems such as obesity, addiction, heart disease, homelessness, and violence. Are we receiving high value for the amount of money spent on health care? Do we get what we pay for? There are health disparities, and these are based on gender, race, and socioeconomic status. The U.S. infant mortality rate is among the highest in the world. The U.S. life expectancy is lower than in many other developed countries. So when we discuss healthcare financing, there are four sources of payment. There's the government, which is 45%. That would include Medicare and Medicaid. Private insurance companies, which is 35.9%. Individuals, 15%. And other sources are 4%. So since the government pays for a large percentage of health care, they have a major influence on what happens in health care. The primary payer of health care is Medicare. Part A includes hospital, hospice, home health, skilled nursing. Part B includes providers, medical equipment, and diagnostics. And then Part D, which came into play in 2006, provides drug benefits. Medicaid is a state-level program. It primarily provides care for the medically indigent, blind, or disabled. It provides care for children with disabilities. 50 to 83% is paid by the federal government, and it's based on per capita income of each state. Over the years, different payment methods have been used in health care. There is the cost-based reimbursement, or retrospective. It consists of the cost of providing a service plus a markup for profit. So allowable costs are calculated, and then they are used as a basis for payment. This was used in the 60s and 70s. There's the flat rate reimbursement, which is the prospective payment system. The DRGs are used as the basis for payment. But there has been a concern of variability within a DRG, such as acuity, and needed resources, including nursing. This flat rate reimbursement is based on the payers deciding in advance what the payment will be. If the costs are greater, the provider absorbs the costs. If the costs are less, the provider benefits. Pay for performance or value-based purchasing was introduced in the early 2000s. Reimbursement is based on performance and outcomes. It includes rewards and incentives for those institutions that perform at a higher level. The Hospital Value Based Purchasing Program, or HVBPP, became effective in October of 2012. It allows for incentives, and they are based on how well a hospital performs on patient outcomes, hospital acquired conditions, and patient satisfaction, as well as how much a hospital improves compared to its baseline. So if you look on page 216 in box 12.1, patient outcomes might be things like congestive heart failure, acute MI, pneumonia. Hospital acquired conditions may include retained foreign bodies or falls or development of pressure ulcers. Patient satisfaction might include such things as communication, responsiveness, pain management, cleanliness of the environment, and just the overall score of the hospital. So review those outcomes and conditions on page 216. Managed care is a health plan that brings together the delivery and financing function into one entity. The goal is to decrease unnecessary services, thereby decreasing costs. HMOs would be where a primary care physician serves as a gatekeeper who determines what services a patient uses. With a PPO, the patients have more options for selecting providers and services. And all of these changes do affect nursing. We must think of our practice within a context of organizational viability and quality of care. We must be able to do financial thinking. We must think of our services in terms of value added for patients. We must exercise cost conscious nursing practices, including capturing all costs. We also must focus on patient needs, not provider needs or organizational practices. We should provide evidence based practice for the public we serve. We must incorporate and evaluate new technologies and use research to better our practices. So when we provide cost conscious nursing practices, we understand what is required to remain financially sound. We know costs and reimbursement practices. We capture all charges in a timely fashion. We use time efficiently. We discuss the cost of care with patients. We evaluate cost effectiveness of new technologies. We predict and use nursing resources efficiently. We use research to evaluate the standard nursing practices. There are different types of budgets that every facility has. There's the operating budget. This is the financial plan for the day-to-day activities of the organization. There are cost centers. Each unit has their own cost center. Units of service, full-time equivalents or FTEs, and then those are broken down even further into productive and non-productive hours. There is the capital expenditure budget. This includes things related to the purchase of major capital items such as equipment or the physical plant. An example would be an MRI machine. The cash budget is the operating plan for monthly cash receipts and disbursements. Let's talk about the budgeting process. Each facility has an annual budgeting process. And during this process, data is gathered and planning takes place. Unit and departmental budgets are developed. Cash budgets are developed. There's negotiation and revision and evaluation that's all a part of this entire budgeting process. So refer to box 12-6 on page 226. The evaluation portion of the budgeting process includes variance analysis. Variance is the difference between the projected budget and the actual performance. A favorable or positive variance means the budget amount is greater than what is spent. An unfavorable or negative variance is where the budget amount is less than the actual amount spent. There are other factors that influence variance. Productivity, by definition, is the ratio of outputs to inputs. Outputs are nursing services and are measured by hours of care or numbers of home visits, etc. Inputs are resources used to provide services, such as personnel hours and supplies. One must decrease inputs or increase outputs to increase productivity. So let's talk about the relationship between healthcare financing and nursing. We do need to be financially savvy. So knowing how healthcare financing and nursing affect each other and how to talk in terms of value to care are skills that nurses really need to be financially savvy. We should share information with staff so that they can help identify patterns and select cost-effective practice options that do not compromise quality of care. And that's the bottom line.